Hi, my name is Yolanda and my partners are Jessica and Angela, and our final presentation will be on breast cancer, a genetic review. Here's an overview of what we will be providing in our PowerPoint presentation. First, we will discuss breast cancer from a genetic and genomic point of view. Next, we will be listing some facts, history, and some statistics of breast cancer. We will also discuss who is most at risk for breast cancer. We will be providing examples of questions and providing data that healthcare providers will need when assessing their patients. Next, we will describe what nurses can do for their patients who have this disorder or are at risk for this genetic disorder. We will also discuss the nurse's responsibility when caring for these patients, including who they should be referred to and general information. We will also be discussing what family members can do. Lastly, we will touch base on informatics and legal and ethical aspects of this topic pertaining to genetics. As we all know, our bodies are made up of millions and millions of cells, and they divide and grow in a controlled way. When an individual has breast cancer, the cells divide and grow without their normal control. If there is a mutation in these genes that are listed, the patient will be at higher risk for getting breast cancer. Later in our PowerPoint, we will be discussing under objective data these genes a little bit more in detail. Although there are many facts, history, and statistics on breast cancer, these are a few of the very important ones that stood out. Breast cancer is the #1 cancer that affects women, although it still can affect men as well. It is estimated that 264,660 new diagnoses of breast cancer will occur this year in the United States. A little bit of history on breast cancer. In the 1980s, diagnoses increased and then dropped in the 1990s. In the 2000s, the number of breast cancer reports dropped. On the website, they listed that they believe that there was a drop in use in menopausal therapy, which could have affected those numbers from coming down. From 1990 to 2013, breast cancer mortality has dropped by 37%. This is believed to be happening because more people are getting screened more often versus back in the 1980s, many people weren't getting screened for breast cancer. White and African American women have the highest reported incidence of breast cancer, while Asian and Pacific Islander have the lowest. There is lots of subjective data that we can look at to see if our patient is at risk for breast cancer. There are lots of questions that we can ask our patient. The Susan G. Komen website listed a lot of risk factors for patients. These are a few of them that we have put into our PowerPoint. The first thing we can do is ask our patient how old they are or look in their chart to see that information. If a patient is 40 or less, they have the lowest chances of getting breast cancer. This age group actually accounts for about 5%. Ages 40 to 70, the risk increases, and after the age of 70, have the highest risk. We can ask our patient about their race and or ethnicity. As I explained in the previous slide, white and African Americans have a higher risk. Pacific Islander and Asian American have the lowest risk. Being a female is going to put you at risk as well. Taller in height was listed on the Susan G. Komen website as well. In this set, they describe could have something to do with the growth spurt that occurs since there's an increased level of hormones that are during that time. The height they listed was 5'3" and above. We can also look at our patient's weight. And are they before menopause or after menopause? This actually makes a difference. Before menopause, being overweight reduces the risk, but after menopause, being overweight increases the risk. We can ask our patient about their family history. Do they have anyone in their family who's had breast cancer. This can also increase their risk. We can ask our patient if they have had any children. The older they are, if they have had any children, could be another risk factor. Next question we could ask is, how old were they when they got their first period? If they were younger, this is listed as another risk. Alcohol and smoking intake is also going to increase the patient's risk. Any hormone therapy increases the patient's risk. And lastly, listed on our PowerPoint is medications being taken such as birth control. On the Susan G. Komen website, it actually explained how women who take birth control pills have a 20 to 30% higher risk than women who do not take any form of birth control. And this is while they're on it and shortly after is what it was explaining. Although there is a lot more subjective data that we could look at, these are just some to kind of give you some examples of important things that we should be looking at when assessing our patient.
In addition to collecting subjective data from the patient, it is also important to collect objective data in regards to patient information. Objective data, as you know, is data that can be examined by anyone and still have the same result rather than it being an opinion. So patients should really be asked to complete a several generation family history. A good example or template that we have at our disposal now that we've completed this course is the Genogram project that we have done. So now we all know exactly what the process is to go through with a patient and make sure you're getting a really thorough health history that's, through all of the generations and all of the family members involved. And noting those key points of what their family health history looks like. My Family Portrait is a very helpful tool that is actually developed by the Office of the Surgeon General. It's just a flow sheet for patients, basically, to make it easier for them to go through and create a family health history that's comprehensive and making sure that nothing is missed. And the important part of family history really to focus on for breast cancer specifically is that your risk increases 20% for invasive breast cancer that's based on having a family history of breast cancer. And patients that have had breast cancer in the past are actually at a higher risk for getting breast cancer again than those that have never been diagnosed with breast cancer in the first place. So it is crucial for patients to be following up with their primary care physician and doing those routine screenings on a regular basis. So just something to keep in mind. Continuing on with some more objective data that you could look for in screening your patients for breast cancer in relation to genetics and genomics are the BRCA1 and 2 gene mutations. These genes are the most well-known and most associated with having a high risk for breast cancer. They can be passed to children from either parent, and they increase the type of breast cancer that occurs in both men and women. So let's not forget that breast cancer is actually a risk for both genders. By age 70, if you have BRCA1, if you're a carrier, your risk is 55 to 65% of developing breast cancer, which is very significant. And as one person mentioned in discussion board post, actually, that I found interesting, some women are actually getting these prophylactic mastectomies to avoid breast cancer. So a first-degree relative with this mutation is also a big risk, even if you haven't been personally tested yourself, but you may know that your aunt or your grandmother tested positive. That increases your risk. And we obviously have gone over extensively evaluating a family history in this course. Radiation treatment, if you have that before age 30, so many people that may have had cancer as a child that have gone through radiation. If you have childhood cancer, then, you're increasing your risk in the future for developing breast cancer in adulthood. And it makes sense, even though radiation is what we use to treat cancer with, it is also what is causing a lot of problems. Continuing on with objective data in regards to clinical results, there are honestly several different gene mutations that people can test for, or be tested for rather, to see about developing their risk for breast cancer and how that is increased. And actually, developing polyps in the GI tract is one of the gene mutations that is associated with an increased risk for breast cancer. And then lastly, we have 3 genes that are all working in a similar way to repair DNA or create proteins that inhibit tumor growth. And when those genes are mutated so that the tumor growth inhibition is inhibited, those genes aren't working the same way to do their job and stop the tumor growth, then obviously you're at more of a risk to develop cancers, including breast cancer. Finally, we should be making sure that we're getting the proper screening for our patients. You can do self-screenings at home. It's important to educate patients on how to do a breast self-exam. That's beyond the scope of this PowerPoint slide presentation. But you can also have a clinical breast exam done. Patients should be encouraged to be, whether we're seeing them at the bedside or at a clinic, genetic testing, it may not be in a primary care physician setting, but whatever contact that we have with patients, they should always be encouraged to be going to regular screenings for mammograms and breast MRIs. Those last 2 vary depending on the risk factors. They're very patient specific. So that is why it's really important to be following up with a primary care physician to see how often and when those screenings should be done based on each patient's specificity. Ultimately, as always, we need to be very conscious and proactive that we are respecting our patients' moral and ethical code, whether they feel that they have the right to privacy or the right to know, or whether we feel that we should be warning them about their risks. Ultimately, everyone's healthcare choices are their own, and you cannot determine what patients are going to want for themselves. So it does get tricky in terms of ethics and genomics and family. It's very important to just remind your patients that there are plenty of community resources. Just doing a simple Google search of community resources, even family support groups. And this is really important to remember. Cancer can affect everybody, or any illness can affect everybody. And just because the person isn't diagnosed with it, maybe a family member is diagnosed with it, that doesn't mean that they don't need to be supported. And as nurses, we really don't just have our patients as patients, we also have our families. So just remember that when you're out there offering support to all of these people, to use compassion, as I'm sure you all do.
And now we're going to talk about nursing roles. One thing the nurse should always do is be a patient advocate. These patients are going to be going through a very rough time dealing with, the fact that they have breast cancer, and they won't really know what to do in situations. And a lot of times they look for the nurses to be there for them and advocate for them with the physicians and their family and their support staff. They really want to have their families know that the nurse is willing to be there for them as well. Which leads me into my next thing, which is the patient support system. These patients, like I said, are going through a very rough time. They need the support from their nurse to know that the person that's taking care of them is giving them the best care and will always be there to listen to them talk and vent or anything that they need to do. And they also look at the nurse to be there for their family and the people that they love because they aren't able to be there, which could be anywhere from their mothers to their children to their sisters, basically anyone that is willing to be there for the family. Another part is the pharmacology. The nurse plays a huge role in making sure that the patient is getting the proper medications that they need for their health. And if we as nurses don't make sure that the patient is getting the proper medications, it could cause more harm to the patient than good. And then the precautions regarding safety, this kind of just was thrown in there regarding the patient. They have to have standard precautions. Some even need masks and gowns worn by everyone in the family so that they aren't transmitting any diseases or viruses or bacteria that they might be bringing in with them. They also have to limit how many people can actually come into the room when a patient has breast cancer or any type of cancer and they're receiving chemo or some type of other pharmacological drug. It's more of protection for the patient than from everyone else. Now regarding referrals, obviously the number one referral would be oncology. A nurse needs to make sure that the proper oncologist is there and that the proper care is being taken for the patient. Another thing, since I work in surgery, a lot of patients have been receiving acupuncture. This helps with the pain and the stress and the anxiety of everything that breast cancer can give to these patients. This can definitely help with the problem of that and take away the pain. A general or a plastic surgeon, this is more of because a lot of the times breast cancer or tumors or other issues regarding the cancer can be taken care of with surgery, where they'll go in and do like a mastectomy. Some even will get the high risk patients will get mastectomies just so that they don't have to worry about it in their future because they are considered a high risk through genetics. A lot of them will just go and get a mastectomy done by a plastic or a general surgeon. Another referral would be financial planning. This is just because obviously hospitals are not cheap. Hospital stays are not cheap, and one of the providers of the family is currently not able to work because she or he are dealing with breast cancer. So financial planning or a financial planner would be very helpful to this type of family because they are able to help them through the difficult times. Family and self-counseling, this is more for the family and the patient. The patient and the family are both going through this at the same time, which is something we all have to remember, that it's not just the patient that's dealing with these problems, it is also the family. And a lot of the times these counselors are who can talk to the patient about furthering making sure that their children or their mother do not have the same genes as she does regarding the breast cancer. And another one is the support groups, because we all need support. We have to remember as nurses that we sometimes will need support for the rough times or the difficult conversations that we have to have with these patients. We need support. The patient needs support. The family needs support. And surprisingly, sometimes the doctors need support because they can't handle doing everything on their own either. And finally, regarding legal, ethical, and informatics, pharmacology compliance, we have to make sure that these patients are following the proper guidelines with their pharmacology when they do go home. Have them have a home health nurse. That's another referral that I could have put on there. We need to make sure that everything is being followed appropriately. Another one is the future studies regarding a cure or therapies. This is more falls into the ethical guidelines of should a patient try it, should they not, is it ethical, is it appropriate. This is all things regarding that where the ethics team could be involved. Another time where legal and ethical will be involved sometimes is end of life, which is not something that we like to talk about. However, it is a possibility, and a lot of times with wills or patient wishes, we need legal and ethical to be there because the families don't know what to do in that time, if they should or shouldn't, or if the will is even appropriate, because if the patient hasn't filled out a will, sometimes they're not coherent or able to make a living will at that time, so then family has to take care of it and they don't know what to do, so they have to call in the ethics committee. Trials with new medications, this is definitely falls within the future studies. It definitely can become an ethical issue where, is it appropriate for the patient? Is it actually going to help the patient? Should the patient do it? That's another issue that can come up. And then the 3-generation pedigree. This is more of where the patient needs to look at it and look at if they have children or their mother or grandmother, if they've all had it. It might be a good opportunity for them to fill out a pedigree to see if it's skipping a generation or skipping every 2 generations, so that future generations know to get tested, or if they're high risk, so that they possibly could get that mastectomy to prevent any issues from happening.